Right. I am going to kick us off. Good afternoon and welcome. My name is Dawn Wyatt. We are thrilled to have everyone join us today. This was a very popular conversation and an initial kickoff of a webinar series that we are producing from UW Medicine. Today's topic, let's talk about pregnancy and the COVID-19 vaccine. We are very excited to start this conversation, and I will turn this over to our panelists and lead experts. A little house cleaning or housekeeping for today's session. We are recording this and we'll be pushing out this recording to everyone who's registered. This was a very popular session today, so we're hoping that many people will be able to see this when we push this back out. If they're not able to register and attend today, later they can see the recordings. We will be providing the presentations. Just note that all of our participants, those of you who are registered, will be placed on mute and your video will not be showing. We do have a live Q&A available to anyone for questions that you'd like to submit during this program. So please, at the bottom of your screen, if you would like to submit a question, utilize the Q&A session. You've got a series of people behind the scenes who are going to be monitoring and checking out some of those questions while our experts are having a good conversation with you. For those of you, just to be able to see both the slides and our experts, you'll have a few people who are non-video participants. You have the availability in the top right-hand corner of your screen to hide non-video participants, and that way you will limit their names. So with that, I am going to hand this over to our moderator, Mary Lou Copas, who will walk us through today's program. And thank you everyone for your participation.
Thanks, Dawn.
Thank you.
Welcome, everybody. I know I have some patients out there. I saw some people this morning who said they were going to try to get in, and apologies if you talk to people who didn't get in. You will get a recording of the session. But I know a lot of people have a lot of questions and a lot of interest, so we're hoping to get to a lot of that. So we're going to start with just a brief presentation of some information from our three panelists here, and I'll act as moderator. I'm a midwife at the UW Medical Center Northwest, and after we do a brief presentation, then we'll get to your questions. And we have some of your questions that you've written out ahead of time and submitted, and also there'll be some live questions that we'll get to. So I'll start with Elisa Kachikas. And did I say your name right? I should have asked that ahead of time.
Yeah, perfect.
Cool. So Dr. Kachikas is a professor of maternal fetal medicine. That means that she's an OBGYN who has done a further training in a specialty in high-risk pregnancies. And so she's a professor of maternal fetal medicine, and some of her expertise is in global health and health equity, but she also does a lot of research in infections and immunization in pregnancy. So she's going to give us a little bit of information about COVID and the vaccine. So I have the slideshow up, so just tell me when I need to advance. Okay. Oh, you're muted, Elisa.
There we go. Okay. Well, great. Good morning. And like Mary Lou said, I work in maternal fetal medicine, work clinically, but then I also work in doing quite a bit of research on maternal immunizations, which are the vaccinations in pregnancy. And then specifically now with the COVID-19 vaccine, also COVID-19 vaccine in pregnancy and lactation. I wanted to start my part of the presentation by kind of going backwards a little bit and talking about what all the fuss is about with the COVID-19 vaccine. And specifically, we're talking about the COVID-19 vaccine specific to Pfizer and Moderna, which are mRNA vaccines, and then the COVID-19 vaccine in general. So kind of looking back at what type of vaccines we know about and what type of vaccines we have right now. There are different platforms, and the ones that we're really familiar with in pregnancy and in general are the protein-based vaccines, for example, the orange kind of vaccine on the right side of this little graph. And protein-based vaccines are vaccines that most of us have received. For example, the hepatitis B vaccine, Tdap vaccine, those are all protein-based vaccines. And the way that they work is that the protein gets injected into our bodies recognize that that protein is foreign, mounts an immune response, makes some memory, and then every time we encounter that protein on a virus or a bacteria, our body can fight back. Another type of vaccine that we know about and we have a lot of experience with are these virus type vaccines. So weakened viruses that we can inject into our bodies. So like the MMR vaccine is a attenuated virus, so weakened virus. And then also the influenza vaccine, one of the forms is a virus vaccine. Those are not recommended in pregnancy, but we have a lot more experience in those in the general population. Another type of vaccine platform that we have some information on too is the green option here, the viral vector vaccine. And an example of that would be the Ebola vaccine. Now, we don't have a lot of experience with that in the United States, but it is something that we have used before. And then the new vaccines that we're talking about right now are the nucleic acid vaccines, the kind of blue vaccine there. And I'm going to go a little bit more in depth talking about the mRNA vaccine because I had to kind of educate myself about this at the beginning when Pfizer and Moderna were coming out with their vaccines about what this vaccine does and how it might impact our bodies. Mary Lou, if you could move forward. So as opposed to the protein-based vaccines, for example, the protein is injected into our body. In this case, mRNA vaccines, so messenger RNA, is injected into our bodies. And what happens is that mRNA, the messenger RNA, it's kind of like an instruction pamphlet or manual. The mRNA goes into the cells, and mRNA in general in our bodies, we make mRNA all the time. mRNA tells our cells how to make a protein. And the specific mRNA in this vaccine tells our cells how to make the spike protein, which is a protein that's found on the outside of the coronavirus. So when the mRNA tells our bodies to make the spike protein, the white blood cells can see that the spike protein is foreign to our bodies and then mount an immune response, make some memories, and be able to fight back if we encounter COVID-19 or the SARS-CoV-2 virus in real life. The mRNA, that kind of instruction manual, is then broken down by the cell, so it doesn't stick around for long. And there have been a lot of discussions on social media about what mRNA means. I just want to emphasize what it does not do. It does not cause COVID-19 infection. There's no virus in it, just the mRNA. It doesn't interact with our DNA. So our DNA is housed in a part of the cell called the nucleus. Kind of the command center of all of our DNA material or genetic material, and the mRNA does not go into the nucleus. And it's broken down really quickly by the cell as soon as it kind of starts producing that protein. So that is a little bit of information on the mRNA vaccine. You can move forward. And in general, just a little review about vaccines in pregnancy. Vaccines in pregnancy can be very beneficial, and we use them for different reasons. And we give them at different times in pregnancy because of these reasons. So one reason we give a vaccine in pregnancy is to protect the pregnant person from infection. So an example of that would be the influenza vaccine that we give, which is protein-based. We give the influenza vaccine in pregnancy at any time during pregnancy when it's available, because we know that pregnant people who have influenza in pregnancy tend to have worse outcomes than non-pregnant people. And by protecting the pregnant individual, we protect the fetus, we protect the placenta, and ultimately also the newborn baby. So that's why we give the influenza vaccine in pregnancy, and we give it any time in pregnancy. Another vaccine that we give a lot in pregnancy is the Tdap vaccine, the tetanus, diphtheria, and acellular pertussis vaccine, the whooping cough component. And the reason that we give that one in pregnancy is that we have data from research studies showing that if we give the Tdap vaccine during pregnancy, even if a pregnant individual has had the Tdap vaccine within the last 10 years, that boost in antibodies kind of makes the antibody transfer across the placenta. So the placenta actually works actively to try to push over antibodies to the fetus during pregnancy. That boost in antibody actually helps the baby ultimately after delivery have higher antibody levels. And we know that babies who get pertussis within the first year of life can have really severe sickness or even death. And the reason we give the Tdap vaccine in the United States, we give it at the end of the second trimester, early third trimester, because as pregnancy progresses, the efficiency of the placenta increases. So the placenta gets super fast at moving antibodies over. And so we give that Tdap vaccine towards the end of pregnancy to help boost those antibody levels for the baby. The pregnant person benefits too, but a lot of it is for the baby in this case. Now,
and then also, whatever the mom may be immune to from having exposure or having vaccination is going to pass to the baby and give the baby some of that passive immunity.
Yes, yes, correct. And there can be, well, yes, exactly. Now, that being said, we do not have data right now on how any antibody generated from the COVID-19 vaccine crosses the placenta. That we do not know. We've just been starting to give COVID-19 vaccine in pregnancy very recently. There is a little bit of data coming out, slowly trickling in about transplacental antibody transfer for kind of wild type COVID-19 infection, but we still need a lot more data on that to have any conclusive opinions about how that goes down. Sometimes antibody transfer depends also on what type of antibody it is, how it's structured, etc. So it's very variable.
So not all types of antibody will go to the mom. We can suppose that some antibody will go to the baby, but without data, we can't say for sure.
Right, and the type of antibody that goes to the baby is that IgG antibody. So the kind of mature type of antibody, not the IgM, which is that acute infection, a big antibody, it's the IgG that would cross over the placenta. Okay, next slide. So where are we now? Excellent question. So what happened with the COVID-19 vaccine is that in the fall, when there were clinical trials, a few organizations kind of raised their hand and said, hey, in these trials, we really need to get pregnant women or lactating women involved so we know more about how they do with the vaccine. But it's pretty typical that pregnant women or pregnant individuals were not included in those initial clinical trials. Then when the FDA in the US kind of reviewed the vaccine from Pfizer and from Moderna, they said safety data is great, it's effective. All individuals over 16 or 18 years old can get this vaccine. And then kind of as a response to that, the organizations that are really involved in pregnancy care in the US, like the Society for Maternal Fetal Medicine and the American College of Obstetricians and Gynecologists, put out statements saying, you know, listen, pregnant women are at high risk if they get COVID-19 infection. They should be given the option of getting the vaccine even though there's no data. So that's kind of where we are right now. And I know that some of you have heard that the WHO put out a statement, and I'm going to come back to that in the end. But that's where we are right now. We basically have this recommendation to at least offer the COVID-19 vaccine to pregnant individuals or lactating individuals without any data. And so that's where we are on this slide right now. There is no data on the COVID-19 vaccine that's been published for humans. Now we do have DART data, which is the, one second. We're not quite there, Mary Lou, but almost there. DART data is developmental and reproductive toxicity data, which is when we test the vaccine in non-human mammals. And both Pfizer and Moderna have now put out their DART data, and there are no safety concerns with that. So that it's something, but it's not human data. Now we are collecting data right now, and I'll kind of talk about that too. But, and hopefully there will be some data out soon, but we don't have any data right now. Next image. Historically, looking at how pregnant women do with, or pregnant individuals do with vaccines though, there's no reason to think that pregnant individuals, lactating individuals would not do okay with the COVID-19 vaccine. So we know, number one, that pregnant individuals can mount an immune response to vaccines, we know that. Not with mRNA vaccines, but with other vaccines. We also know that pregnant individuals can receive vaccines without severe side effects, minus the live virus vaccines like MMR. Again, those are not recommended in pregnancy, but we do know that vaccines in pregnancy like influenza, Tdap, and even some others that we don't routinely offer but could be given, like hepatitis B, don't cause severe side effects in pregnant women. And then we also know that the fetus and the neonate may benefit from having a vaccine in pregnancy. We just don't have clear data on that right now with the COVID-19 vaccine, but we will be getting that data in the future. So historically speaking, there's really no reason to think that there'd be increased adverse events in the pregnant individual or in her fetus or in the neonate with this COVID-19 infection or vaccine. And the next image, Mary Lou.
Okay. Is it working?
There we go. Great. What we do know is that pregnancy is a risk factor for adverse events and with COVID-19 disease. So studies from the CDC looking at national data and also from our state with the Washington State COVID-19 and Pregnancy Collaborative have shown that pregnant individuals with COVID-19 have a higher risk of being admitted to the hospital, needing to be in the ICU, needing to have mechanical ventilation, so being intubated, and then also needing ECMO therapy, which is kind of when you get put on a bypass machine and your blood gets oxygenated without your heart and your lungs. So we do know that. Now, that being said, a lot of pregnant women get COVID-19 vaccine and a lot of them do well, but there are higher risks with pregnancy. Next little image, Mary Lou. Yeah, and the big thing is too that we know that there are certain risk factors that predispose to adverse events with COVID-19. So in individuals who have certain comorbidities or certain conditions, for example, if your BMI is 30 or above, or if you have diabetes or kind of chronic cardiac or pulmonary conditions, we know that you might be at higher risk for having severe COVID-19 disease and events. So emoji, what shall we do about this? And I'm going to pass over to Dr. Underwood, but one thing I want to mention about the WHO statement that just came out. The context to this is that the World Health Organization, or the WHO, just put out a statement saying that the Moderna vaccine should not be given to pregnant individuals unless they have certain comorbidities. In reading that vaccine and then the reaction from ACOG and other organizations, the WHO doesn't have any data that other people don't have. So what their statement is a product of the fact that we have no data in human pregnancy. It's not that all of a sudden they found that there were adverse events somewhere. So they're doing what typically has been done historically to say there's no data, so therefore pregnant individuals should not receive the vaccine. In contrast, the Society for Maternal Fetal Medicine and the American College of Obstetricians and Gynecologists put out a response saying, we know that there's no data, but there's also no data to the contrary that pregnant people would do worse with the COVID-19 vaccine. So therefore, it should be up to the individual plus or minus discussion with her provider about whether or not to receive the COVID-19 in pregnancy, depending on items that Dr. Underwood will go.
So the WHO came out with a different opinion based on the same lack of information. There's not any new information.
There's no new information. It's just, historically speaking, through the decades, if
don't give it to pregnant women, and pregnant women are left out of treatment that they may need.
Right, pregnant people have been seen as vulnerable and not included in research, and so therefore we don't have data, and therefore they say we don't know if it's safe, and therefore they're not included. But we do know that pregnant individuals are at risk for higher adverse events with COVID-19, so this is a conundrum. But one point of view is to say, well, at least give the option of getting the COVID-19 vaccine. And then the other point of view is to say, probably not unless you're like super high risk.
Right, makes sense. Thank you. So is this, Esther, is this your first slide?
Fine.
Or that's Portia's. Okay, so sorry, I have my order wrong. So next I'm going to introduce Dr. Portia Underwood, and she is a professor of OBGYN and practices at the Women's Health Clinic at Harborview and also at Roosevelt Women's Health. So she's a clinical instructor. She did a residency at the University of Colorado, and I think in the last year came to us, right?
Yes, that's correct. I just got here in July.
Well, I just got to meet her through doing this, working on this project, so I'm excited. So you talk to patients all the time, and I'm sure are fielding some of these questions. So what do we do with this? We know that pregnancy is at higher risk, and then there are certain individuals who even have more risk factors, given other medical or social determinants of health. So how do you help people decide what to do?
Exactly. So this is a conversation that we want to encourage between the pregnant lactating persons with their providers to have. Similar to what Dr. Kachikas alluded to when we think about the risks of COVID-19 in pregnancy, because that's what we're weighing, the risks of this virus with the theoretical or concern for risks with the vaccination. Overall, the absolute risk for severe COVID infection is low, but similar to what Dr. Kachika says, we know that pregnant persons, when compared to similar symptomatic patients who are not pregnant, they're at an increased risk of needing to be in the ICU, needing mechanical ventilation or ventilator support, and unfortunately even death. And so that's why we are trying to figure out how to assess the safety of this vaccination and encouraging patients to get it.
So we know that older people are more at risk. So if I'm pregnant and I'm like 35 years old, I'm at higher risk than my friend who's 35 years old and not pregnant.
Exactly. And that kind of leads, to the next question. So what else besides pregnancy puts an individual at increased risk of complications associated with COVID? So when we're taking a bigger step back and thinking about what all kind of goes into that risk factor, one thing to think about is the level of the virus in the community. So are you in an area where the prevalence is high? Or are you in an area where things are a little bit calmer and there are not as many active cases that are going? In addition to pregnancy, we know that patients or individuals with cancer, things like chronic kidney disease, COPD, history of heart failure, or having a history of an organ transplant, obesity, and specifically the BMI greater than 30, and even a severe obesity with the BMI greater than 40 puts you at increased risks, as well as having sickle cell, smoking, and type 2 diabetes. When we are looking at other medical comorbidities or other medical conditions, we know that there are things that might put people at increased risks. And those are conditions like asthma, cystic fibrosis, hypertension, having a blood or bone marrow transplant, HIV, steroids, or any medication that we know of that can weaken the immune system, liver disease, and then being overweight, which is a BMI of 25 to 30, as well as having type 1 diabetes. Outside of just medical conditions or medical comorbidities, we know that there are differences in race and ethnicity and how people are being, exposed to and suffering from COVID-19. So we know that similar to the general population, Black and Hispanic individuals who are pregnant have higher rates of COVID-19 infections as well as death. And then when looking at our Asian populations, we know that there were higher ICU admission rates in our Asian pregnant persons. So
Sorry, can I ask about do we think that that's because, or I guess we don't really know, but do we think that that's because people in certain races and ethnicities are more likely to be working in jobs that put them at higher risk and living in communities or maybe more multi-generational homes, et cetera? I mean, is that what we speculate?
Yeah, a good question. There are a lot of different both social and structural factors that compound this effect that we've noticed. So some of it's access to care, some of it's rates of underlying chronic medical conditions, like you mentioned, occupational exposures, socioeconomic statuses, as well as just inequities that exist within our healthcare system at baseline.
So it's a combination of all of that.
Exactly, yes.
Just like everything else.
So then other things. to encourage or to discuss with your provider is, how does the vaccine affect routine prenatal or postpartum care? We know, as Dr. Kachikas talked about, that there are vaccinations that are typically given during pregnancy, such as the flu vaccine or the Tdap vaccine. And with that, we know that the COVID-19 vaccination should not be administered within 14 days of getting one of those other vaccines. And so coming up with a good plan for timing of administering the Tdap as well as the COVID-19 vaccine is important. In addition, RhoGAM, which is a medication that we give to pregnant persons who are Rh negative, is not affected by the COVID vaccine. So it's possible to get that done at the same time or on the same day, same visit as well. Not necessarily specific to administration of the COVID vaccine, but we have noted that prenatal care has been evolving in the setting of the COVID-19 pandemic. And so there is options for incorporating telehealth and tele-OB into low-risk pregnancies to help limit some of those exposures to the COVID-19 virus.
Yeah, we've been doing some of that in our clinic.
Exactly, yes. And for many of our patients, it's been a welcome change, limiting some of those barriers to transportation, access, and that sort of thing. Side effects is a big concern. So what do our patients do if they are having side effects? What type of side effects have been reported? Typically, patients who have had the vaccination report very mild flu-like symptoms. Usually when we're thinking of those, it was fever, and fever was more common after the second dose of the vaccination, and that was in both the Pfizer vaccine as well as the Moderna vaccine. And importantly, most of these symptoms resolve by day 2 or 3. For our pregnant and lactating persons, we recommend Tylenol or acetaminophen to be taken if these symptoms are bothersome. We know that having those medications on board after getting the vaccination doesn't impact the antibody response. Also, supportive care is reasonable. So feeling a little bit crummy, maybe drinking some tea, curling up on the couch with a book is also one way to kind of deal with some of those undesirable side effects.
Similar to like people getting cold or flu when they're pregnant, most of the time it's a mild, rest, push fluids, take some Tylenol.
Exactly.
When you're not sick with the vaccine, you're having a reaction that is your immune system doing what it needs to do to create antibodies to the illness.
Exactly. It's telling us that the vaccination is working and our body's doing what we expect it to do. And kind of like I was saying, it's not that all people are going to get these sort of side effects. I believe it was in less than 20% of people after the second dose of the vaccination. So even though we have this vaccine, not everyone feels comfortable or ready to get the vaccination at that time. So what do those people do? How do we, approach that conversation with our providers? Support is the biggest thing. This is still new information. Information is evolving every day. So we just need to keep the lines of communication open and keep revisiting things at subsequent visits with the follow-up for your provider. Other things are just preventing your exposure risk for the COVID infection. So continuing to wear a mask, continuing to socially distance, staying at least 6 feet away from other people, trying not to go into large crowds or areas that are high risk for exposure, making sure that we are doing hand washing with soap and water or a hand sanitizer that has alcohol in it. And then from a larger standpoint, keeping in mind those CDC advised travel guidelines, quarantine guidance, and following any recommendations by your employer. Another question that has come up is that what about if I'm planning to get pregnant? How should I approach or start thinking about getting that vaccine? It's important to note that you do not need a pregnancy test before you actually get the vaccine. And as Dr. Kachikas alluded to, based on the mechanism of action and the safety profile, we're not concerned that this vaccination would have effects on fertility. So we're not worried about an increased risk of fertility to be associated with this vaccination. And even if you are planning on getting pregnant and you happen to get pregnant between the first and the second dose, we still are encouraging all pregnant and lactating people to get that second dose. And so I think the gist of this is to really engage and question and keep in mind that information is changing, but we are here to answer those questions and provide reassurance when we can.
Great. Portia, a lot of people that I'm hearing from are wondering if I'm going to get the vaccine and it's indicated for me in pregnancy and I think I want it, should I avoid it in the first weeks of pregnancy? Should I avoid it at the end when I'm close to going into labor? Any thoughts on that and how you counsel people?
Yeah, so I haven't seen anything that gives specific recommendations at times to avoid this. I think a lot of the information we have is in the second and third trimester, but when comparing those risks of the COVID-19 infection with the mild side effects of the vaccination, I haven't seen anything that recommends avoiding certain time. Dr. Kachikas, if you have any other thoughts, I'd be happy to hear those.
No, there's no specific there's no specific data. There's no data, but also no specific recommendation for trimester. I think if you're really, really early in your pregnancy, I think it would be reasonable to think about waiting just a couple of weeks. But first, second, third trimester, there's really no specific recommendation. And again, this vaccine is kind of like the flu vaccine, right? So the benefit of it, we don't know much about antibody transfer, so hopefully your baby would benefit. But the big benefit is that you yourself will not get COVID-19 in pregnancy.
One question people are asking is, do we know anything about the mRNA transferred from the placenta? So could the vaccine be transferring through the placenta? Do we know anything about that?
I don't think so. I think that would also just need to be studied to see if that specific mRNA ends up in the fetal circulation. But I think that based on how quickly it's degraded, I don't think the chances of that would be very high.
Thanks. Sorry, Dr. Underwood.
Oh, that's the conclusion of my section.
Okay, great. Thank you. That was really helpful. So next I'm going to introduce Dr. Chung. Esther Chung is a professor of pediatrics at the University of Washington School of Medicine and also Seattle Children's Hospital. And she works at the Roosevelt Pediatric Clinic. And she has some expertise and research in breastfeeding and in maternal fetal medicine, so the baby inside. Basically, you've been working as a pediatrician for the past 30 years and for vaccination of newborns and children's against all kinds of things. And here's a new one. And a lot of people are asking things about breastfeeding, and I'm hoping, Dr. Chung, that you can answer some of those questions.
Thank you so much, Mary Lou. In addition to being a doctor, I'm also a mother, a partner, a daughter, and a friend to many who share your concerns and questions about the COVID-19 vaccine. As a mother and a pediatrician, I thought a lot about vaccines, and in the past 30 years as a practicing physician, I've seen over a dozen new vaccines added to the routine vaccination schedule for children. And every time a new vaccine comes out, we all have lots of questions about, has it been tested enough? Will I be the one person who has side effects or complication? So we share your uncertainty, and we're here to provide information today. And though I have also had the opportunity to treat the occasional side effects of vaccines, including fevers, aches, and allergic reactions, I've also witnessed huge reductions in illness, hospitalizations, and loss due to infections such as influenza, hepatitis A and B, and rotavirus vaccines. So Dr. Kachikas and Dr. Underwood have done a great job already providing you with information about COVID-19, the vaccine, and pregnancy. And in the next couple of slides, I hope to provide you with clear information that will aid you in your decision-making, particularly as it pertains to COVID-19 vaccine and breastfeeding. And so just to reiterate a few points that have already been made, first, we'd like you to consider your risk of COVID-19 infection and the possible associated complications and consequences of getting the infection, your loved ones, your household members, your coworkers, and others that could impact. Next, we'd like you to consider the benefits of COVID-19 vaccine and the common side effects that have already been described. And then lastly, we want to provide you with enough information so that you can make an informed and shared decision with your healthcare provider. When it comes to COVID-19 vaccine and breastfeeding, let's talk about current recommendations and what we know. So what did the expert recommendations say in the United States? Well, the Academy of Breastfeeding Medicine, which is an organization made up of the physicians who are breastfeeding advocates, in their official statement noted that there's a biologically plausible benefit where breastfeeding mothers may pass stimulated immune, that is T cells, and protective antibodies via breast milk after receiving the COVID-19 vaccine. Similarly, the ACOG, which was already mentioned, the American College of Obstetricians and Gynecologists, and the Society for Maternal and Fetal Medicine, in their official statements, they recommend that lactating individuals should be offered the COVID-19 vaccine when they are eligible based on the various phases of vaccine rollout. And then of note, I had a colleague who sent me information from the Society of Gynecologists and Obstetricians in Canada who also agree. The CDC, or Centers for Disease Control and Prevention's Advisory Committee on Immunization Practices, also known as ACIP, suggests that an informed decision be made between breastfeeding mothers with their healthcare professionals. They also note that the COVID-19 vaccine is not thought to be a risk to the breastfeeding infant. So what are important things to know about the vaccine that have not already been mentioned? Well, some of these have been mentioned, so forgive me if I'm repeating some things, but I'd like to reiterate some things. Unlike other vaccines, these vaccines do not contain any preservatives or adjuvants. And that's because they were not necessary for the vaccine to be effective. And keep in mind that this reduces the risk of an allergic reaction or side effect from added chemicals. Secondly, as already noted by Dr. Kachikis, these vaccines are not live virus vaccines. They're rapidly degraded and they do not impact DNA or our genes. Importantly, the vaccines were tested from people of various racial groups. And this is very important to me as an Asian person, but also important to me as a physician who cares for a diverse population. For example, 10% of study participants in the Moderna study were Black or African American, and 5% were Asian. And similarly, in the Pfizer BioNTech studies, 9% were Black or African American, and 4% were Asian. Safety data from animal models to date have shown no impact on fetal or infant development, and safety is being closely monitored. So over 15,000 vaccinated pregnant women have already enrolled in the Center for Disease Control and Prevention's registry called VSafe, which we'll talk about in a minute. And there are a number of other studies currently enrolling vaccinated breastfeeding individuals. And then I'd just like to reiterate some of the past experience that was already mentioned. Well, we know from individuals who have had COVID-19 disease that the antibody response to the vaccines is very similar to the antibody and immune response seen in individuals who've been infected. Breast milk from mothers with COVID-19 infection contained COVID-specific antibodies, and this suggests that vaccinated mothers are likely to have COVID-19 specific antibodies in their breast milk. Prior vaccines are safe in breastfeeding infants, so pregnant women at varying time points have safely gotten flu vaccine during flu season, which could include any trimester, as already mentioned, and then pregnant women have also received Tdap vaccine. In the next slide, if we could advance.
Sorry.
I just want to touch on some important facts that relate to you, your families, and children. There have been 25.6 million COVID cases to date, and over 10% of these infections have been in children. We should keep in mind that COVID infection in children is not typically severe, but there is a rare complication referred to as MIS-C, or multisystem inflammatory syndrome. So there's still a lot we don't understand about this infection. And we all respect everyone's efforts to social distance and get through this very difficult pandemic. The graph on the bottom left shows new cases in children per week continue to rise. The good news is that 20.7 million people have received at least one dose of the COVID-19 vaccine, and 3.8 million have been fully vaccinated. The map to the upper left-hand part of the slide shows vaccination rates in various states. And in less than 6 weeks, our country has been able to vaccinate more than 7% of people living in over a handful of states. So that is really quite a feat. Though the published Moderna study focused on adults, the Pfizer BioNTech vaccine included people as young as 16. So there's more information that's going to be coming out about vaccination in children. And every day I see new news about announcements on including children. For example, Pfizer BioNTech, they have announced that they've completed their enrollment and they have enrolled over 2,000 children ages 12 to 15. Moderna is actively enrolling 12 to 17-year-olds. And these studies are being done in hopes that the vaccine against COVID can be made available to children as soon as possible. More exciting news is that Oxford University in England will start trials in children as young as 6, and Johnson & Johnson will also be including children in their upcoming trials. So that's all the information I have to add, and I'll turn it back to Mary Lou.
Great, thank you. So I guess if a person, Dr. Chung, otherwise is a candidate for the vaccine, if they're breastfeeding, do you think they should have any hesitation to get that vaccine?
No, because I think the points that Dr. Kachikis and Dr. Underwood have already mentioned, that the risk of getting the infection is so much higher than any potential risk from the vaccine. And there is already safety data as well as efficacy data about the vaccine that's now available.
Great. So we've got a bunch of your questions here that I'm going to get to as many of them as we can. I have typed some answers to a few of them. Someone is wondering, do we have any idea why the WHO came out about the Moderna and not the Pfizer vaccine? Does anyone know anything about that?
I don't know specifically why Moderna versus Pfizer.
Okay. Let's see, I'm going to go back to the beginning. We asked about the mRNA passing the placenta. I think you answered this one about the severity of impacts in pregnancy. It sounds like one of the more common things is just being overweight or obese, which is not that uncommon these days. That is a significant risk factor in addition to pregnancy. So someone's asking, I'm in the 3rd trimester of pregnancy and have COVID. Do we know how this will affect my baby? Dr. Chung, you want to take that? Sorry, you're muted.
Could you please repeat the question, Mary Lou?
Sorry. I am in my 3rd trimester of pregnancy and have COVID. Do we know how COVID will affect the baby?
I think to date, we have found that babies do quite well, and we were doing pretty routine testing among babies who were born to mothers who were COVID positive, and I'm happy to say that most of them were negative. We feel very reassured. I'd also love it if Dr. Kachikis and Dr. Underwood could also add and share their experience as well.
I think one of the risks to the babies with COVID-19 in pregnancy, especially severe disease, is the risk for needing to be delivered prematurely. So I think if you're doing well, for whoever answered that question or asked that question, if you're doing well, then that's great. But when pregnant individuals do have severe COVID-19, we worry sometimes that we may need to deliver, just because sometimes in the 3rd trimester, especially, the fundus is really high and breathing can be impacted even without COVID-19. So that's one of the risks to babies, just the fact that they may need to be delivered a little bit earlier. But if you're doing well, then that's great. And like Dr. Chung said, I agree, we've seen that the babies do really well afterwards.
And there's a theoretical risk of passing it to the baby, but we think that that's extremely rare.
Agree.
So here's a question that probably is for you, Dr. Kachikis. How long is it expected to get some data on pregnant women receiving the vaccine? A few months, a year, or more?
I think to have some data in a few months. I think, there are several studies. I've answered some questions here. There are several studies in the US. I think the CDC is conducting a study with the vSafe app. Here at the University of Washington, we have a registry that you can sign up for. And then we just launched a large longitudinal outcome study with women all over the country. And I think it's really exciting to see the data roll in. But I think we're kind of waiting to see the specific we ask a bunch of questions about reactions to the first vaccine dose and the second vaccine dose, and I think we just want to have enough people who received that second vaccine dose and see what their side effects were before we publish data. But I think data will be coming out fairly soon for both individuals who are pregnant and lactating or just planning pregnancy. So we should have some data out in a few months, just not right now.
And I would mention that we have some links at the end of our presentation And that includes the link, if you are pregnant and getting the vaccine, you can sign up for the registry.
If you're pregnant or not pregnant or planning a pregnancy, or you're not planning on getting the vaccine, actually, we'd be interested in your opinions on that too. It's almost like all comers, except for males, the people who cannot get pregnant. But yes, we'd be interested, and we'd love for you to be involved in that study.
And I don't know that we have an answer to this, but one question is, do we know how long is the protection post-vaccination?
No, what I would say though is that, again, pregnant individuals do really well with vaccines and have similar immune responses as non-pregnant individuals. So we know from Moderna that the immunity lasts for a while, but we anticipate that boosters will probably be necessary for COVID-19 vaccine. Now, boosters, once a year, kind of like the influenza vaccine. Hopefully it won't be like really frequent. But there's no reason to think that immunity in pregnancy, although we have no data, would be different or significantly different than non-pregnant adults.
But obviously they don't have data for a year yet. They just have data for a few months.
I think, yeah, exactly. I think Moderna has a little bit longer perhaps than Pfizer, but exactly, this is the problem. We're working really fast. It's actually really great and really historic that these vaccines have come out so quickly.
And then they'll continue to follow these people, and more data will come out, and they'll follow tighter levels possibly and recommend boosters based on that, like we do with other vaccines.
Yeah, I assume that will be the case.
And this is a similar question, I think. Do we expect the immune to last during the whole pregnancy? I would expect so.
Yeah.
Based on your answer.
That being said, there was one question about whether people still need to take the same precautions after they've gotten the vaccine, and the answer to that is absolutely. We know that Pfizer and Moderna have published really high efficacy rates, so up to like over 90%, maybe 95%, but we know that vaccines are not 100%, and it could be that you did not respond well to the vaccine, so taking all the precautions is still important. And particularly around people who may live in your household that still haven't gotten the vaccine, but that may be at higher risk for COVID-19, severe COVID-19 disease.
That's a really good point. So for now, we can't just assume that you can't get COVID and your loved ones can't get COVID just because you got the vaccine. Yeah. May we get there. So this is actually, I think, an interesting question. Have there been past experiences where vaccines were given to women in pregnancy that ended up negatively affecting the baby post-birth or years later? Dr. Underwood, do you want to field that one?
Yeah, there's none that I am personally aware of. I think we know to avoid the lab vaccinations, so measles, mumps, rubella, varicella, but as far as any other vaccinations, nothing that I'm aware of.
And my understanding is the live vaccines that we don't give people in pregnancy, that's a theoretical risk. It's not actually that we have evidence of harm caused by the vaccine.
Agree. It's a theoretical risk. So back in the 60s maybe, when they did mass immunization campaigns, this is typically how vaccination happens and how we gather data on pregnant women or pregnant individuals. Mass immunization campaigns happen, pregnant individuals are excluded, but reproductive age individuals are included, and then we find out later that they became pregnant. And then we follow those pregnancies to see if there are any adverse events in the fetuses. And those studies, especially looking at rubella, did not show that there was a significant risk to the fetus, but just out of theoretical risk, we just say not to give or not to take any live vaccines.
The rubella disease can cause birth defects.
Yeah, congenital rubella.
Vaccines. Okay. Well, that's actually reassuring. How directly do studies in animals correlate with humans? Are there examples? People are smart and asking some pretty interesting questions. Are there examples of vaccines or drugs that were safe in animals and safe in pregnancy in animals and caused harm in humans? Can you think of any examples there?
I don't have great examples on this. All I know is that, again, research in pregnancy in general is a little bit lacking. When we look at how medications work in pregnancy, we have animal data usually before studies are even done in pregnant individuals, and the animal data, typically the medications are giving at much higher doses in pregnancy. And so we study that, and then just anecdotally, usually they conduct studies on different types of mammals, but that would be, I can't think of any specific example of a vaccine or medication being okay in all animal studies and then not being okay in humans. But there may be some.
Okay. Are there any concerns for individuals who have miscarried in the past? And I'm thinking that for an individual who is particularly concerned about that, I don't think theoretically there's any increased risk with the vaccine, but that person I might counsel to maybe wait until you're 8 or 12 weeks to get the vaccine, to be on the extra safe side.
Yeah, I think if there's any concern about that, then, you know, if you feel like you're relatively protected at your work or at home, then I would say there's not too much of a downside of just waiting for a few weeks, at least kind of getting out of that really early pregnancy, especially if you've had multiple miscarriages. That I don't think that there would be any concern about waiting a little bit.
Right.
There's one question here about whether, if you're not considered high risk, whether you should get the vaccine. And I think that's kind of something that Dr. Underwood touched on. She can answer that a little bit more if you'd like. But, you know, just discussing any risk factors with your provider and seeing what your occupational exposure is or your home exposure. The bottom line with COVID-19 is that we assume that most people will be fine with COVID-19 infection, but there are some cases of long-lasting effects of COVID-19, and we just don't know individually how people will do, but it would be something to discuss with your provider. Dr. Underwood, do you have any thoughts?
Yeah, agreed. I think it's that, you know, shared decision making to kind of figure out what's best for you. And there may be conditions or exposures that you've had in the past that put you at increased risk that you yourself aren't aware of. But through that conversation and history taking with your provider, you are able to elicit. And so I agree with going in, having that open discussion and really kind of tease through what your specific risks are and exposure risks are.
And I think that kind of answers this other question that says, if I am considered high risk, do you recommend that I receive the vaccine? It sounds like that's more of an individual assessment.
Yeah, exactly. We know that there are certain, you know, high-risk conditions that can predispose to more complications of COVID in pregnancy. However, it's a personal decision and one that you and your provider should feel comfortable kind of talking about and really assessing your individual risk factor.
Great. And I think
sorry, Mary Lou, I don't want to interrupt too much. I just did, though. I think there's a question here, and I want to be very clear about getting the vaccine in the first trimester. There's no data to say that it's not safe to get the vaccine in the first trimester at all. I think there's no recommendation about what trimester to get it in. I think if you feel that you're high risk enough or you qualified to get the vaccine and you want to get the vaccine, there's no reason to wait. It's just that if you've had an obstetric history where you are more likely to have not abortions, that's how we say it in medical terms, but miscarriages, and you feel like a little bit concerned about how any concerns about how the vaccine could affect your pregnancy because we have no data, I think it's totally legit to wait. But there's no recommendation about waiting until the second trimester or third trimester. So getting it any time in pregnancy is based on the lack of data that we have. It would be totally fair to get it any trimester in pregnancy.
And the lack of known harm from other vaccines that we give.
Right.
So, yeah. And I think that makes sense. I think it's a very individual thing. If, you know, I have the similar questions with the flu shot. I can tell you there's great data that the flu shot is safe at any time in pregnancy, and we give it any time in pregnancy. But if you personally are just going to have more peace of mind if you wait, then for you, that may be the right thing to do. I think we answered this. I received the vaccine around 10 weeks pregnant. Was there a reason why you had recommended waiting until the first or second trimester? I'm not sure what that question is. The answer would be just get the second vaccine whenever it's due, 3 or 4 weeks after the first, no matter the trimester.
No reason to delay, even if you find out that you're pregnant, in between getting the first vaccine and the second vaccine. So.
If there's a possibility of the immunity passed to the fetus, do we know how long the immunity stays with the baby post-delivery? Dr. Chung, is that anything you could at least tell?
I wish we had an answer to that question. It kind of relates to not having the information because testing hasn't been done. But we do suspect that if there is immunity transferred, that the antibody would be present for some time.
And with other vaccines, we know that it sticks around.
That's right. And then also in the chat, I saw a question about transfer of antibody to a breastfeeding baby if a mother were vaccinated. And the comment I have about that is that we know from past vaccinations related to viruses that IgA, which is a type of antibody, has been found in breast milk about 5 to 7 days after vaccination. And so that's very hopeful that could be a possible benefit of having the COVID-19 vaccine in a mother who plans to breastfeed.
Here's a question. If we sign up to be part of the study, can we get the vaccine through the study? Unfortunately, the vaccine you get if you qualify for the vaccine.
Yeah, I wish if there were, but one thing is we will be starting likely soon a COVID-19 and pregnancy randomized controlled trial for people who are otherwise not eligible to get the vaccine. So stay tuned for that, but we're working to be one of the sites for one of the clinical trials that are now finally starting for pregnant women or pregnant individuals.
Great. And I think that answered a couple other questions here. And I think we answered how common is COVID in babies and toddlers? I think Dr. Chung, you responded to that one. And
Right. Very not common. And if the infection happens, it tends to be relatively mild. And nevertheless, because there's still a lot unknown, we want to do our best to try to protect anyone from COVID infection. Mary Lou, I wonder if we want to at least show some of the resources since we only have a few minutes left.
Yeah, I see Dawn coming on.
Exactly. I was gonna, there are so many amazing questions. This has been just incredible. And I want to thank all of you on this panel for your expertise and knowledge and just having a very informative conversation for everyone who's registered today. We will, again, we have been providing information along. Everyone has spoken about some of the vaccine resources as well as the registry that is available. We'll be, again, we're recording this conversation and we'll be sending as well these links, valuable links to some of the resources that you can take advantage of in the near future. I also want to tease up, and again, to all our panelists, thank you for your expertise and all the amazing work that you guys are doing to help support all of the people and individuals who are interested in pregnancy or are pregnant. So this has been amazing, and thank you. And then it wouldn't be, I want to give justice to, this is an ongoing webinar series that we are producing. This is a partnership between UW Medicine, our colleagues at Bright as Rain, which is a publication produced here by UW Medicine and a valuable resource to all. We'll be pushing out the next in our webinar series that we're going to be starting to do on a monthly basis. So take a look for that, and we'll be sending out invitations to everybody who registered. But next month, we will turn the conversation in the Let's Talk About series to the vagina. So just a healthy conversation about women's health.
It's a beautiful graphic.
Thank you. Yeah, so we're excited to have that conversation, and we will be providing specific dates and our panelists for that session that's coming to you at the end of February. But again, I'd like to close with thank you to all our panelists. Thank you to everybody who registered. We'll be providing this information out. Hopefully early next week, you'll get a finished recording session. So again,
And all
thank
the
you.
links will be there.
Exactly.
List of links.
Exactly.
Great.
Wonderful. Well, thank you all and have a great afternoon.
Thank you.
Bye.
Thank you.